Starting.
Good afternoon. My name is Yanti and I'm the program specialist with IMI. I'd like to welcome and thank everyone for joining us for the 8th and final session in the Doula and Perinatal Community Health Worker and Medicaid Virtual Learning Series. I want to begin by thanking our partner, Every Mother Counts, as well as our funder, the Community Health Acceleration Partnership, for their commitment to advancing important perinatal health topics in the Medicaid population. We are able to offer this free learning series because of their generous and ongoing support. It is hard to believe we have come to our final session of this dynamic series. I've been so honored to work alongside an amazing project team and some wonderfully impactful speakers and panelists for each of the sessions. Our commencing session 1, high value, equitable, and evidence-based community-based perinatal support, laid the foundation for all of the sessions to come by emphasizing the impact and evidence supporting doulas and perinatal community health workers, and culminated in a rousing call to action from none other than Jenny Joseph. During session 2, we dove into program and training models for community-based perinatal support. I still am using the many notes and quotes from Azza and Jessica and Sarah that I jotted down in this session back in January. In February and March, we tackled contracting, credentialing, and payment mechanisms and state-level highlights of implementation. We had doula leaders from the East and West Coast, and brought into focus in session 4 by none other than Amy Chen from the National Health Law Program's Doula Medicaid project. And then in the past 3 months, we tackled ways to capture value and demonstrate impact in Medicaid with a vibrant panel discussion that included conversations around data, including the landmark study by Sister Webb as shared by Ali Quintos. In May, I remember the thought-provoking comments from Dr. Pepper Wilson and Chanel Portia Albert when discussing ways to ensure community engagement, equity, and accountability in Medicaid. And last but certainly not least, in our most recent session last month, we learned about ways to build the doula and perinatal community health workforce using collaborative systems of support from panelists from 3 community-based organizations, Grow Doulas, Birthmark Doulas, and Healthy Start Brooklyn's By My Side support program. I'm so proud of the work that we've done together to advance birth equity throughout this series, and I'm excited that it's not over. We still have an amazing session today and much more to come. This series has been dynamic and change-making thanks to everyone who has participated in any capacity, most of all, the over 1,000 participants who have been on this journey for the past 8 months with us. As a refresher, we will place the link in today's pre-session materials in the chat. To participate in this discussion with the speakers, please use the Q&A feature to submit questions and comments. We encourage you to submit questions throughout the session. Any unanswered questions will be consolidated and shared with our presenters and project team after today's session, and we will send out responses with the post-session materials. Before we hear from our speakers for this session, we would like to continue the tradition of emphasizing the importance of avoiding placing the burden of addressing all maternal health inequities solely on the shoulders of doulas and perinatal community health workers. Access and coverage of doula and perinatal community health worker services in Medicaid is just one element of a multi-pronged approach that is needed to support system-wide transformation. So now I'm going to hand it over to my colleague Andrea to provide some grounding for today's subjects and review our session's learning objectives.
Good afternoon. My name is Andrea McGlynn, and I'm the Associate Director of Programs at the Institute for Medicaid Innovation. It is my pleasure to share this session's learning objectives with you today. I'm going to kick off the session by spending a few minutes talking about part of the session title, the nitty-gritty of billing, and our first learning objective, the infrastructure, systems, and processes that support community-based doulas and perinatal community health workers in navigating Medicaid coverage. Medicaid is health insurance, and the primary job of health insurance is to pay for health care. So when we say support doulas and perinatal community health workers, we mean at minimum get them paid. A good starting point is to stack up the key building blocks, terms, concepts, processes that when all put together, set up the system to get Medicaid providers paid. So first, a couple of key terms, billing and claims. Claims are statements submitted for reimbursement. Claims state what service was done, by whom, how much of it, when and where, for whom, and how much is owed for the services. Providers create claims. Billing is the act of submitting claims. In Medicaid coverage of doula services, doulas and maybe their support team bill for doula services by submitting claims. The role of the Medicaid agency or the Medicaid managed care organization is to process and pay the claims. For those claims that get paid, a lot of building blocks need to be in place. There usually needs to be a way for the provider to be identified in the system, such as a provider ID number, sometimes a national number, sometimes an ID within the state Medicaid system, sometimes an ID that the Medicaid managed care organization has, and sometimes all of these. Provider groups can have IDs as well as individual providers who work in groups. Systems may associate IDs with provider types so that the system can sort all the providers of one type to match the provider to pay them the right way, or to report a statistic such as how many doulas are enrolled as Medicaid providers. In addition to the provider ID and type, there may be other building blocks related to the provider who submits the claim. And then there are building blocks related to the services on the claims. There are service types. Usually each of the service types has a code, otherwise known as billable codes. The other information about the services might be units of service, like number of hours or number of visits, place of service, like home, hospital, or other places. The date of service is important, and there may be more about the service. Claims usually need to have details about the person receiving the service. This information is about the person who has Medicaid health insurance. The Medicaid provider has to get this information from the person themselves or from a system that Medicaid providers and others who help with Medicaid coverage can request access to. Information needed about the person receiving the service might be their Medicaid enrollee ID, if they're actively enrolled or eligible at the time of service, which Medicaid MCO they're enrolled in at the time of service, their age, date of birth, other demographics, if they have a certain condition or diagnosis like pregnancy or other requirements that pertain to the person. The process of submitting claims has building blocks too. Some systems have a specific method of submitting a claim, like electronic portals, specific forms. There might be more than one option. There may be time requirements or when claims can be submitted, like not before the date of service or within a certain time after. The actual building blocks and their shapes and sizes and color in each set are a bit different from state to state and managed care organization. The state or the MCO may stack them up differently in their own system. Medicaid providers have different ways of organizing the building blocks. We've heard in many of our sessions that it works best when doulas and the Medicaid agency or MCO get together to set them up to ensure that claims can be paid for a high value model of care. That's what's on the table, held up by all the building blocks. As we've heard in our learning sessions in this series, there's no single solution for Medicaid coverage of community-based perinatal support, no one way to set up doula services. Different communities have different needs, service gaps, strengths, and resources, and each state has its own systems, regulations, and requirements. But there are a lot of common elements that we've explored, like core competencies, support systems, ways to organize caseloads, ways to be accessible and center the birthing person and the communities that birthing families live in. By sharing successful practices and perspectives from all of the stakeholders in this series, we have offered a menu of options to help inform the design and implementation of perinatal support programs. That's why it's wonderful we have such a wise panel today to focus specifically on what matters most, how we work with the building blocks. This relies on the people, communication, innovation, and working through ideas collaboratively toward the desired goals. Those are our second and third learning objectives. Operational processes that facilitate equitable and effective coverage of community-based perinatal support, and considerations for billing and benefit design to maximize successful reimbursement for community-based doulas and perinatal community health workers. With that, it is my privilege to introduce our speakers and Dr. Caitlin Cross-Burnett, our moderator, the interim division director at the Division of Special Populations Research at the Innovation Center within the Centers for Medicare and Medicaid Services. I hope you have a moment to read Dr. Cross-Burnett's bio in the link we will place in the chat, and all the bios. Dr. Cross-Burnett's role and tenure at CMS allows her to share national perspective and expertise on the importance of doulas and perinatal community health workers in Medicaid. And her work and passions beyond CMS make her uniquely wise and supportive of community-based perinatal services. As you have asked us to call you Caitlin, we're delighted you could join us for our last session, and take it away.
Thank you so much. Thank you so much, Andrea. And thank you to everybody for being here, and to IMI and all of its partners and funders for putting on such an important series and working to increase equity and access for people who are going to be giving birth in this country. We are so fortunate to have this group together to talk a little bit about the practicalities of implementing doula services on the ground through Medicaid programs. As Andrea pointed out, it can be a really complex process. There isn't a single roadmap that will work, but I think that the examples that our amazing speakers are going to be giving will give people ideas that will be transferable to other contexts, and will also emphasize the importance not only of doulas being paid and community health workers being paid, but of being paid fairly, so that by serving Medicaid patients, we aren't creating a dual system that's separate for rates for people with private insurance versus Medicaid insurance, and that we are making sure that we are treating our doula population fairly as well as our patients fairly. So I'm absolutely thrilled to be able to introduce Bobby Monahan to speak as the director of a provider network management system at AmeriHealth in Washington, D.C. Thank you so much, Bobby. Take it away.
Thank you so much, Caitlin. It's an honor to be here, and thank you so much, IMI, for having me. I'd like to take a few moments to speak to everybody about AmeriHealth Caritas and who we are. Again, we're going to talk about doula services in the age of 2023. Next slide, please. AmeriHealth Caritas District of Columbia, who are we? AmeriHealth Caritas District of Columbia, we are committed to providing our enrollees with access to quality health care and outstanding enrollee services. We have a 30-year history of serving Medicaid communities and utilizing our long-standing community ties to deliver health care in the District of Columbia. We also are part of the AmeriHealth Caritas family of companies, a national leader in providing healthcare solutions and managed care. Next slide. I, alongside my team, work in what's called the Provider Network Management Department. The Provider Network Management Department represents AmeriHealth Caritas within the provider community. Our department consists of dedicated employees who play a crucial role in establishing and maintaining relationships with our valued providers. One of our primary responsibilities is to ensure that our providers have a smooth process when obtaining necessary approvals and permissions for their patients' care. Next slide. Additionally, we work closely to collaborate with our community outreach coordinators, acting as a liaison between the physician practices and our organization. This partnership enables us to assist with appointment scheduling, engage in patient outreach, and ensure a seamless and coordinated healthcare experience. We also work alongside of our discharge planners and guarantee a smooth transition for our enrollees from hospital, lower levels of care, and/or into the community. This involves helping secure any essential documentation needed during this discharge process, as well as ensuring well-coordinated range of care services are provided to our enrollees. In summary, the Provider Network Department serves as a vital interface between AmeriHealth Caritas and our provider community. Through our dedicated team and comprehensive services, we strive to support our providers, optimize care coordination, and ultimately enhance the overall healthcare experience for our enrollees. Next slide. Doula services at AmeriHealth Caritas today. AmeriHealth Caritas District of Columbia began offering doula support services as a value-added benefit to our enrollees in 2015 via a single community-based organization, Mama Toto Village. Since that time, our services have expanded from prenatal and labor support to lactation support, childbirth education, and coordinating of social determinants. Mama Toto Village also utilizes community health workers to engage pregnant persons in maternal care. Working in the community, they have a greater successful engagement rate in meeting our enrollees where they are. They also have a non-clinical model which provides education, life skill trainings, and referral to community services to address social needs as well as respite for new mothers after delivery. And lastly, they provide lactation consult services to support breastfeeding and maternal infant bonding, as well as labor support from training workers or doulas for clients enrolled in their services. Next slide. So here at AmeriHealth Caritas, we decided to develop what we call a value-based program for our doulas. And this is just another way for us to stress to our provider community how important doulas are and the services that they provide in the provider community. So the name of our program is the Perform Plus Bundle for Babies Doula Services. And AmeriHealth Caritas Bundles for Baby Doula Services program recognizes the role doulas can play in supporting positive birth outcome and patient experience. The program is designed to provide financial incentives to doulas to support birthing parents and improve maternal health outcomes. First part is the postpartum visit. The doulas can earn $100 after completing a postpartum service visit when the client is seen by an obstetrician clinician for one postpartum visit between 7 and 84 days after delivery, in addition to submitting a claim for the delivery. Episode efficiency, episode case rates are evaluated against the target practice at the end of the measurement period. And if the average episode case rate is below the target practice, doulas can earn a portion of the shared savings. And lastly, access to care. Doulas are eligible for an additional PMPM incentive based on the number of members that they offer services to in effort to increase access to these services. Next slide. Certification requirements. I thought it was important to make sure that the provider community understands what we as AmeriHealth Caritas look for when we're credentialing our doulas. And we try to adhere to the certification requirements for a number of the doula certification programs. And I'll go through a couple of them. We accept the certification for Doula Trainings International, Black Doula Training, formerly Black Doula Institute, of course, Mama Toto Village, International Childbirth Education Center, and Maternity Wise. Next slide. Doula enrollment requirements. Again, we have our Encompass list just like a lot of the payers, but I figured I'd highlight some of the most important pieces of documentation that's actually necessary in this process. Here in the district, all of our providers, not just doula, have to obtain a DHCF Medicaid provider ID number. So this is a process where the provider has to register themselves with the District of Columbia. As a MCO, we cannot move forward in the process unless our providers obtain this certification number from DHCF. So again, that's a very important process for all of the MCOs here in the District of Columbia. There's a professional doula certification needed, an NPI and taxonomy, proof of liability insurance, of course, the W-9 form, the highest level of education, and we perform what we call a site visit. So if the doula is performing services at a dedicated location. We as a health plan go out and we ensure that dedicated area is safe, that it's clean, and that there's emergency preparedness information listed, exit signs. So again, we just make sure that the doula is practicing in a safe environment that is a healthcare compliant as well. Next slide. Our billing guidelines, and I'm sure this is probably a part of the most important part for any of our providers who want to contract with us. We are allowed 12 prenatal and postpartum visits, including attendance at the delivery. There's 12 visits included and a maximum of 1 doula consultation that can be allocated across the perinatal and postpartum period. Each perinatal service before, during, and up to 6 weeks of delivery shall be billed and reimbursed per visit, regardless of the length of time. And postpartum service visits shall be billed and reimbursed separately as a unit of service and shall be billed in 15-minute increments and reimbursed at a per unit rate. Lastly, a postpartum service visit shall not exceed 24 units or 6 hours per visit. Next slide. And again, this is public information from the District of Columbia's Healthcare Services website. And these are the codes that we implement in our contract along with the reimbursement rates allocated from the district. There's a perinatal doula support visit and the corresponding code along with the reimbursement rate for that. There's a doula support delivery code for vaginal delivery, for a C-section, and for a VBAC, along with the same appropriate reimbursement standards. And the postpartum doula support visit that's billed in 15-minute increments, and also the 99199, which is the additional incentive that's billed between 7 and 84 days after the delivery. Next slide. And again, to kind of speak to what was spoken to earlier regarding the claim submission. At AmeriHealth Caritas, we encourage all of our providers to submit claims electronically. We have a 95% rate of processing clean claims within 30 days. Any electronic and paper claims received for our providers, they have a 365-day submission period from the time that the services were rendered. And also too, in this education process, we educate the doulas, advise them that services should be submitted to us on a 1500 claim form. Again, to emphasize, we encourage all of our providers to make claims electronically to us. We give them our payer ID where they coordinate with their clearinghouse and set this process up to transmit those claims to us electronically. And in that same space for our providers who are in the process of transitioning to electronic capabilities, we provide them with the address to submit claims to us via paper at our post office box. Lastly, that's it. Thank you so much.
Thank you so much. I'm really struck by how much goes into developing a program like this and the kinds of things you brought up to think about. The importance of both the business side, but also the community and personal side, how critical it is to maintain relationships, to conduct community outreach, to make sure everything is coordinated across all of the important stakeholders through the hospitals, clinics, providers, the community itself, the patients who are going to be served, and how critical it is to consider the quality outcomes as all of that is going on. Also, how important it is to do some pre-thinking when you are going to start a program like this about things like what will be the requirements for doula certification, the outline of, all of the requirements that are needed and what the billing guidelines might be. This was so helpful and informative and so thorough in really thinking about all of the angles that people need to consider when they're building a business case for doulas or a method of incorporating and reimbursing community health workers and doulas. Please remember, everybody, that you can see full bios for our speakers through the link in the chat. And now we are honored to be able to get some comment from a person who is actually practicing in the doula space and working on the business case from that side of things. Kenda Sutton-L from Birth and Color RVA. Thank you so much for joining us, Kenda, and please take it away.
Thank you so much for having me, and welcome everyone, and glad you're excited about the doula reimbursement model and what it actually looks like. I am the executive director of Birth and Color. Next slide. What is Birth and Color? Birth and Color provides pregnant people, support to pregnant people to ensure a safe journey to parenthood and make better decisions, their children, and linking maternal justice to reproductive justice. We do have a doula collective. We operate outside of Virginia, and we do operate in Maryland as well. Next slide. These are the services that you can, that Birth and Color actually provides: community support groups, trained breastfeeding specialists that offer breastfeeding support. We do lactation clinics that are free to the community. We also keep baby items in stock to support families with need. We also host community baby showers in different cities at least twice a year. And then we do advocate for policies that support minority women and people, and also families. Next slide. Community doula overview. What is a community doula? It's a non-medical professional that provides continuous physical, emotional, and information support to pregnant people prenatally, through pregnancy, and during labor and delivery. Period. We focus on health equity and also social determinants of health. We provide referrals and connections to critical community resources. And then we do partner with birthing parents and their medical team to facilitate that communication and to also help parents feel empowered to navigate through the medical care and make choices that actually align with their birthing plan, but also keeping in mind that making sure that community members realize that birth plans are just a plan. They sometimes birth is unpredictable and then it does change. So making sure that they understand if it actually has to change and why, providing that support. Next slide. How community-based doulas are assisting in maternal mortality crisis and bias in healthcare in communities that typically experience significant inequities in maternal and infant health outcomes. Community-based doulas provide programs are reducing barriers to access and prioritizing peer support. Doulas can provide individually tailored cultural congruent care and advocacy for parent and postpartum people through information, education, physical, social, and emotional support. While doulas cannot eliminate individual and institutional racism in the medical system, doulas can help improve the maternal health experience and address health disparities by reducing the impacts of racism and racial bias on pregnant and postpartum people of color. Doulas who understand the physical, social, and emotional support impacts racism can provide much needed support to their clients, and above all, act as their advocates as their clients navigate medical system of care. Next slide. So in Virginia was the 4th state to actually do a doula reimbursement. And how we did that, we did it 2 different ways. We introduced 2 different bills to make sure that we were covering everything that doulas want. And we actually worked together as a team to make sure that doulas' voices was heard, and that also MCOs understood what the value of doulas, and then also that our Virginia Health Department actually understood the value of doulas, and all of us got together to figure out what this should and what it does currently look like. And so we did a HB 826 bill, which was directed at the evaluate. We did a study bill. We did a study to decide on, okay, what is the actual rate that a doula should get? And during this time period, we actually know doula states were paying as much as Virginia. So now that we see all of these great other doula models, we're excited to take this back so that we could get more money and decide on like what other services would we like to add in there and how many more visits would we like to do. Next slide. Then we did the certification bill. We wanted to make sure that we did a legacy clause to make sure that all those doulas, all people who were doulas prior to the start of this were actually just grandfathered in. So that was a great piece of this, as well as making sure that people understood that there's a difference between community-based doulas and regular birth doulas. And our bill specifically talks about community-based doulas in the actual language. And that's how we were able to develop that, because that's two different types of care. So we wanted to make sure that the doulas that were actually becoming Medicaid approved had that system navigation, have that referral system, and has a connection with the community. Next slide. And so doula engagement and buy-in was very, very important to us. And so a lot of the concerns that came with the reimbursement was the concerns from the doula community were addressed by ensuring Virginia welcomed doulas from the very beginning of the process. It wasn't where our state decided that they wanted a doula bill. It was the doulas who decided that we wanted a doula bill and that we were going to follow it the entire way through. So we held doula implementation meetings, work group meetings, webinars, and all of the things. And so then we did a collaboration between doulas, doula organizations, and the state to actually plan out what this could and should look like. And we also developed an inclusive and equitable program for all doulas to be able to participate. Now, within the Virginia, when it comes to the current doula engagement, you have Birth in Color and Urban Baby who are successfully expanding the accessibility of doulas. We're making sure that we're doing doula trainings, maternal health care hubs. We're training in different areas across the state, so that if we say that we have a doula benefit, the whole entire state can actually utilize, because we do believe that everyone should have a doula. And then we have a Virginia task force inside of this as well that was created. And so we do workforce professional development and recommendations. And then we, on a quarterly basis, we actually do meet to engage all doulas to figure out what type of plans do we want, what should be happening and what can be happening, and what is better ways that we can connect with doulas to make sure that they have the infrastructure, that they understand what's actually going on. And so that's really, and also another piece, we did a budget amendment when we entered this bill. So we have a paid position. So we actually have a doula analyst position that helps if a doula has questions or anything like that. That is a paid position that we actually put into legislation. And that person that is in that position is Natasha, and she's very good at what she actually does. And she helps doulas with any questions and making sure that the MCOs are responding in adequate amounts of time and things like that. And so I think that's the last slide. Oh, here are all of the visits that we actually do have. It's a total of 9. We have 1 initial, we have 3 prenatals, and then we have 4 postpartum visits. And a special part in our bill too is that we can provide support to a person who's experienced a loss or a stillborn. So we wanted to make sure that was important. Next slide. And these are just the training requirements. Next slide. And we talked about all of the things that come with community-based organizations, with community-based doulas and the maternal outcomes, and how they can decrease numbers. And we do advocate for certain things. And so no matter what type of birth that you are wanting, a doula can actually help you navigate through the entire process. And I can turn it over to you.
Thank you so much. Are you ready for me to take it back?
Yes.
Okay. Thank you so much for your presentation. I think one of the things that you said that is so critical and certainly near and dear to my heart is the role that doulas play in sort of the greater quest for social justice that we have, and how integrated all of this is in thinking about not just support during pregnancy and birth, but also for quality parenting, for lactation, for overall social and reproductive justice, for making sure people have the specific things that they need, baby items, and also policy advocacy for families, and how all of that is really interwoven into something in which doulas are such a critical part but also pointing out that doulas cannot solve all the world's problems. We can't make doulas solely responsible for the impacts of systemic racism. But one thing that we can all do to try and combat that is make sure that people do have access to doulas and do have access to doulas who are culturally appropriate for their own background and who understand what they need and are going through and can serve as the best advocates for them. So this is all, just so interwoven and so important for all of us to recognize the importance of developing these kinds of payment mechanisms to make sure people get this kind of care. And how important it is also to empower doulas at the grassroots to be advocating for themselves and making decisions and helping to develop the policies that will support them, and to make sure that they're the ones with the voice and that it isn't all, coming from the legislators down or from Medicaid policy down, but also down probably isn't the right word, across. But to make sure that we really are activating doulas' voices in the kinds of services that they're going to provide and what their own communities need, and making sure that they get paid appropriately for that. So I wanted to ask a couple of questions for both of you before we get to other Q&A. So I wanted to start off by thinking about that kind of community and grassroots base. And Bobby, you were talking about starting off with partnering with community-based organization, specifically Mama Toto, to provide your members access to doula and perinatal CHWs through Medicaid. Can you talk a little bit more about why it was so important to start with that community base as you developed your program?
Sure, Caitlin. Thank you so much. And I think that's a great question. I oftentimes tell people that I have the pleasure of working for an organization who oftentimes speaks to doing what's best for the enrollee and providing the best services and access to care for the enrollees. And so back in 2015, AmeriHealth Caritas recognized that there was a need in the community for doula services and a need to cover these services for enrollees. This was not something that was a covered benefit under the policies that we offered. As a plan, we decided to cover these services and allow our members to have access to them through a value-added benefit. So we partnered with Mama Toto Village because we felt it was important to establish trust and cultural competency within the community-based organization, because we know that oftentimes they have established relationships and trust within the community they serve, and they want to build up on that relationship. So we understood that, we wanted to tap into that, and we wanted to work with them to kind of expand that. We also wanted to improve access and awareness, again, within the community for AmeriHealth Caritas and for Mama Toto Village. We wanted to expand our network and direct connections to a targeted population, and also to expand upon this because we understand that these community organizations are embedded within the community and they have a pulse on specific challenges and barriers that our enrollees oftentimes face. So again, partnering with them, with these organizations also too allows a better dissemination of information, raising awareness and the ability for the doula and prenatal visits to be educated for throughout the community. We also too wanted to enhance the program outcomes because we felt that Mama Toto Village could help us do that in this space. They could address any concerns and any false impressions about doulas and the services that they offer. Lastly, partnering with a community-based organization who has access to doula and perinatal benefits is important because it capitalizes on established trust, improve access and awareness, and provide tailored and cultural responsive services to enhance program engagement and outcomes and fosters sustainable collaboration for long-term impact.
So I'm really hearing some of what you had also emphasized in your presentation about how important all the different layers are to making this work, getting those pieces together with the community and the patients really being essential components of that, not just thinking about this as a clinical arrangement. Kenda, could you speak a little bit on that in the sense of how you feel that these areas are really critical for doulas, about this, the support that you're getting from health plans and organizations to get doulas to more people? What kinds of things are happening in your experience that are really critical for making the actual process happen so that people are actually getting the doulas?
So, great question. Thank you, Caitlin. One of the things that we actually do is word of mouth has been one of our biggest advertisements. And then also working with the MCOs. So their case managers, all of those people are referring and saying like, hey, do you have a doula? Do you know what a doula is? So we have great connections and great care with all of the MCOs. And one of the things that we actually put in our benefit is that we have to be paid within 14 days, which helps also because those community doulas are also able to just remain community doulas full time. They're not having to work 2 different full-time jobs just in order to actually be a doula. And that's a piece that people don't really always talk about or think about when we're talking about connecting people to doulas, because we have to have enough doulas enrolled to be able to connect them to make it make sense. Because if you have a large state and you have all these organizations that are training doulas, but those doulas are having to work at different places, sometimes that referral piece is not going to run over so smoothly if other key pointers aren't actually in place as well.
So I heard you talking about the 14-day billing, turnaround, which I think is a really, really important point so that things don't drag out and people are getting paid on a regular basis and can develop their own budgets. Are there other supports that the state has put in place to facilitate Medicaid billing that support doulas?
So if you're working for an organization, the organization has put things in place. As far as the other things, not as of yet. We do have where the organizations were the ones that were testing out the billing to make sure it ran smoothly. We do have the doula implementation meetings that are ran by the state that actually we have MCOs on the call. We have OBs on the call to make sure that everyone is welcoming doulas and providing that support to the doulas. And so that's a key piece that we actually do have from our state. But also the engagement piece is us communicating to say like, hey, this is working, what's not working, what we do like, what we don't like. And so it's been a year since we actually started. And so we're actually being able to see what those outcomes really truly look like. And our state, like now we're going back, and we do have the doula task force as well, which is from the state, where we all get together and we talk about, okay, this is how we can change here. Oh, this is the support that we're actually looking for and that we actually do need.
Really just impressed by both of you and like the continuous talk about how much engagement needs to happen across so many different systems and people to really make this happen and keep it going. So Bobby, to turn this sort of same kind of question to you, how do you feel like state or Medicaid MCOs are supporting operational efficiencies for actually putting this benefit forward? How are MCOs and health plans making sure that they can implement a Medicaid doula benefit sort of overall? I know you explained how your own organization was doing it and all the work that they had. What would be your main takeaways for what other MCOs might be doing, or additional things that could be done, or things that we should just make sure are at the top of our list?
Sure, and I think a lot of the information has already been shared. So I'll just kind of highlight. I think the most important part of this process and what's made it a little bit easier is that there's a partnership and a collaboration between the MCOs in our area, the district, and our doulas and our maternal providers. I along with myself and some of my coworkers, attended these work groups where we received feedback from the doulas. And in this feedback, they talked about what they thought would work best in the sessions or in the implementation, and where they would think that maybe the MCOs and or the district would have an opportunity for improvement in that process. So I think the biggest part of this was the collaboration process so that we could identify any barriers on the front end, and in the implementation process, we could try to work through those barriers because we had a firsthand knowledge of what the doulas could potentially think they would be, so that from a systematic perspective, we could align and configure our system to accept the codes or accept the reimbursement, and also to futuristically think about how we can partner again in the space and increase additional awareness.
And to follow up on that, Kenda, when we're thinking about this kind of billing and infrastructure support, why is that so important for community-based doulas?
Um, why it's so important is because doulas are looked upon as the saviors of this, right? Of like all the people who are going to, and that's not true. And so when you think about the support, you have to think about the history of the doula and why the community-based doula is so important. And so if we're going to be taking all of that time away from them to actually think about, to teach them like, okay, you need to build this, you need to do this, who is actually going to be educating them on what the billing truly looks like? And so you have some that are from the community. We wanted community-based doulas for a reason, because they're from the community. And so sometimes they might not have that billing degree or might not have the administrative knowledge of what that could look like, what you need to be prepared for when it becomes an audit. All of those things are going to be key factors, which is why collaborating with the MCOs so that they know, okay, what does your billing look like? What type of support is actually needed? And then also delivering that information to the state so that they can put infrastructures in place to make sure it makes sense, or that they can put community-based organizations in charge and give them funding to make sure that the infrastructure is there so that an organization can just bill for a number of doulas.
So let's think about that a little bit. So I'd like each of you to answer, Bobby and then Kenda, what kinds of small business supports exist that could assist community-based organizations? What can we leverage that we have in that sort of small business support space?
No, Dr. Kayla, thank you so much. And I think that's a great question. I think a big part of it, Kenda spoke about reimbursements. And that's why, as an MCO, we have worked to ensure that our system is set up to ensure that we do pay claims according to our state or our District of Columbia policies. Again, we have a percentage of 95% where we're processing all of our clean claims within 30 days. So as we're out and we're cultivating our relationships with the providers, we're speaking to, hey, these are the appropriate codes for these services. If you're completing the 1500 form correctly, then you ensure that you receive payment within 30 days, sometimes before. Just depends on, what we're doing from a systematic perspective. So again, I think what can happen in that space is funding and grants. Always an opportunity for our doulas to look through the district and see what opportunities can present themselves to them in that space. Networking and collaboration opportunities. We are always looking to partner with our providers to, again, increase our presence in the market, and also to ensure that there's an awareness of who we are, what we do, and in this case, the doula services. And lastly, marketing and promotional support. We can give it in the space of assisting with Facebook Facebook pages, and also too with branding. We've collaborated with the district and some other vendors and some other spaces where we've done some events and we've co-branded. So again, just a plethora of opportunities in that space. And lastly, I think that by providing small businesses with community-based support and offering services can strengthen their operations, expand their reach, and improve overall impact for maternal health services in the community.
Thank you so much. And Kenda, did you have anything you wanted to add to that response?
No, I think she did a great job with answering the question.
Thank you, Bobby. You were perfect. So, but Kenda, just as a sort of tag onto that, is there, aside from the 14-day window on billing, is there a practice, like if you were telling Medicaid agencies what to do around billing, are there other common practices that you would tell them to adopt besides that?
So in Virginia, the organizations actually have a dedicated person that if we submit a claim and it's denied or for whatever reason, we have a dedicated person that we can actually just pick up the phone and reach out to instead of calling the toll-free number and getting the runaround and have to go through this person who doesn't know and this person. We actually have that dedicated person, and that I'm not sure how long it's going to last, but that person is like being able to go in and say like, okay, this is the reason why the claim got denied. Oh, that's a system issue. So we did have to test out the systems and stuff like that because it was a new benefit and they had to do new codes. And so that was extremely helpful. So I definitely think the 14 days, I definitely think having those people in place so that we could talk about it, making sure that the community doulas actually approved all of their marketing and branding. So our providers did not just create their own branding without saying, hey, this is what we're going to say doulas do. This is what we want it to look like. And so we actually had the opportunity to say like, oh no, take this, remove this, put this, add this. And so that was really beneficial for us too.
So I'm merely hearing that how critical it is to have doulas at the table while all of this is happening. And for doulas
Definitely
maybe to
having
bring
doulas
the
at the table.
table and set the table, and maybe make some decisions for themselves about who else is sitting at the table. There's one last question that I would like to hear from you two on, which is one person in the chat had pointed out that now doulas in their state can provide case management services but only to high risk people in Medicaid. It's not a general benefit. And she's asking, do you think that is a good stepping stone toward full doula reimbursement? Or should there be a different approach?
I don't think that that's a good practice, honestly. For one, is because when you look at the maternal mortality rates, it has nothing to do with high risk. It has nothing to do with social economic status. It really has a lot to do with racial bias and like the different factors. So why was that even put there? Did they actually ask any doulas, was this okay to actually do? And so when you think about the term doulas, because I saw where someone had said something about the community doula piece that I mentioned. And so when the reason why that piece is so important when thinking about this whole entire process is you have to think about racism, right? And so when you think about what the birth doula and everyone thinks that it's a luxury, but when you think back to history, doulas were actually created from people of color. They were created from Black women. And so when you think about the term birth sisters and all of that and what we did as a village, and that's how all of this have came to fruition. And that's why we want to make sure that there's no different barriers to the community members or even to the people who wants to have a doula when thinking about what Medicaid reimbursement can look like.
And I think your point about the fact that, the people who need a doula are not necessarily the ones identified at high medical risk, that anybody can be at risk, and that a woman of color, especially a Black woman, is sort of automatically at risk by entering into the system, that we have, which it has shown such disproportionate maternal morbidity and mortality, and how critical it is to have that kind of support in making sure that you can navigate that system and feel, more confident and supported. We're going to have to stop in a moment, but did you want to add anything on, Bobby, before we move forward?
No, I think Kendra did a great job of outlining how important doulas are and the roles that they play. As a health plan, we already have targeted case management services. So again, this is just another component of it that's already been important for us as a health plan to identify and offer these services in that space. So that's something that we're already doing and having great success in that area.
Thank you so much for your contributions and for being speakers and the incredible wisdom that you have shared with all of us. I am now going to turn over the panel to Katie Decker from Every Mother Counts.
Thank you so much, Caitlin and Kenda and Bobby. And hi, everyone. I'm Katie, Manager of Content and Advocacy at Every Mother Counts. I appreciate the opportunity to say a few closing words on behalf of EMC. We're so grateful to have been a partner in this learning series and for the collaboration, partnership, and expertise of our colleagues at IMI. And we also want to extend our gratitude to each of the amazing speakers we've had across all 8 sessions and to all of the participants from across the country who have taken the time to tune in and engage with the series over the last 8 months. As an organization working to achieve quality, respectful, and equitable maternity care for all, increasing access to high-value, evidence-based, and community-driven models of perinatal support is central to the work of Every Mother Counts. We appreciate the opportunity to highlight pathways to expand access to perinatal support services through Medicaid and share and learn from the expertise of community-based perinatal support organizations and providers. We're looking forward to building and strengthening partnerships with stakeholders across the country, working towards the shared goal of achieving birth equity for Medicaid enrolled individuals. My wonderful colleague, Yuki Davis, EMC's former manager of policy and advocacy and a speaker in session 2 of this learning series, made the following statement that I believe encapsulates the goals of the series really well. So the quote is, by being responsive to the community-based perinatal workforce and aligning Medicaid with what is necessary for a community-based perinatal support worker to best serve their clients, I believe we can truly advance towards birth equity, end quote. Thank you all so much again for your participation, and we're really grateful to be in this work alongside you. And so with that, I'll pass it on to Jennifer Moore, Founding Executive Director at IMI, for a few closing reflections.
Thank you, Katie. And all I have to say is, wow, what an incredible learning series. I mean, the learning together, the connecting of the shared commitment to birth equity and justice every month was a highlight, a feature. It inspired all of us. So as we close out our last session today, although it's probably not our last session ever coming together as a group, I want to thank some really special people. So first, our speakers, and we're fortunate to have 3 here today to get this live. We've had national, state, and local experts. They've inspired us that we can do more and that we must do more. And I want to thank all of them for bringing that voice, that perspective, that guidance for all of us who are leading this work. I want to thank you as participants. Over 1,000 people registered for this learning series. 1,000. They represented Medicaid health plans, federal and state government, provider groups and health systems, community-based organizations, and doulas and perinatal community health workers. Thank you for coming together for all of these sessions, to have these conversations, to learn, to grow, to enhance our commitment to this work. We want to thank our funder, the Community Health Acceleration Partnership, CHAP. Without them, this series would not have happened. And so we are internally grateful for that. We want to thank our partner, Every Mother Counts. What an incredible opportunity to work with you, especially Nan Strauss, Yuki Davis, and Katie Decker, who you just heard from. And then finally, I want to celebrate and thank the entire IMI team. So much goes into the learning series, but I especially want to thank Yanti Wheeler, Andrea McGlynn, and Jill Wadnick for their contribution to this series. So with that, I know we have one slide that we're going to pull up. And like I said, it's never actually done, right? This work is never going to be done. The question is, what's next? So we are so delighted to share that we are going to be launching a National Doula Learning Collaborative for partners in Medicaid. This will include state Medicaid agencies, Medicaid health plans, community-based organizations, and most importantly, doulas and perinatal community health workers to come together to identify areas for collaboration, identify pain points and barriers that we can work together collectively to overcome, to implement this model of care to ensure that every person with Medicaid coverage has access to doulas. So the goal is to expand, obviously, the Medicaid coverage of doula services going beyond the states that have already started to commit, but also to provide technical support and guidance for states that are struggling or just starting to launch their own doula coverage. This is important if we want to achieve birth equity and justice. The teams who are selected, it'll be a competitive process, will receive tools, technical assistance, learning opportunities, and resources to lead change through design and implementation of initiatives in their states. And I promise you that everyone who has registered for this learning series will be the first to learn about an informational webinar where we'll share more information about the opportunity, review the application process, answer all of your questions, and prepare for your participation in the next stage of this work. So watch out for those emails and follow us on our website, Twitter, LinkedIn, our e-newsletter. We will be blasting it out everywhere when we're ready to share more details. but excited to share with you firsthand that this is the next step. So with that, again, thank you so much to everybody. And to close out, I'm going to hand it over to Yuki. Oh, sorry, Yanti. I misread that.
Thank you so much, Jennifer and Katie. As a reminder, all materials from today's session, including the recordings, we made available to you on the IMI website about 2 weeks after the presentation date. All of our previous session materials are housed on the website right now. Keep an eye out for further communication from the project team with the recap for this session and any other updates we have regarding this topic. Also, some of you have received communication from me regarding technical assistance calls that we're having with 31 states with participants who expressed interest. We've had calls with participants from Maryland, Tennessee, and Washington already. And then for all of our other states, please be on the lookout for a confirmation email from me, as well as a calendar invite for your TA call if you haven't already received this communication. This has been a wonderful series full of amazing dialogue, thoughtful questions, and impactful recommendations, problem solving, and collaboration. In this last session, we would love to have all participants complete the 3-minute feedback survey. We placed that in the chat. Everyone should have also received an email with a link to complete today's survey as well. If you did not receive that email, please contact me. But we want to thank everyone for your participation, and hopefully you have a wonderful summer. And we'll hopefully see some friends soon. Thank you.